Thank you, Dr. Yasser. It's a very informative lecture. May I present Dr. Mahmoud Labib? For Mohamed Labib, for the preserving the hypogastric is not an option anymore.
Thanks, Dr. Hadia, for a nice invitation for chair in first Damietta Vascular Conference. I will talk today about preserving the hypogastric. It is not optional anymore. 20% of patients with AAA have concomitant iliac aneurysmal disease, which is bilateral in 25% of these cases, with growth rate 1 to 4 millimeter per year. With rupture threshold is undefined, but most commonly more than 5 centimeter. This make this diameter make unsuitable for adequate distal sealing in patient with EVAR. Chekhov et al. At Journal of Vascular Surgery at 2002 identify and aggregate the factors that modify the outcome of EVAR, and he defines the iliac artery hostile anatomy, in which the length less than 10 millimeter and the diameter more than 17 millimeter. Solitary iliac artery it is rare in less than 2% of all aneurysms, most commonly in common iliac artery in 70% of the patients. A lot of complication is associated with unilateral or bilateral hypogastric artery occlusion in the form of buttock claudication and sexual dysfunction, colonic ischemia or perineal necrosis, and spinal cord ischemia. A nice systematic review which include 18 clinical series which involve 634 patients with result that found in their result that buttock claudication occur in 28% of the patient and sexual dysfunction occur in 17% of the patient after internal iliac artery embolization. Another systematic review, which include 394 patients with iliac artery embolization or coverage, and they found overall ischemic complication in the percent of 22.6, and the major was in buttock claudication with 12%. But they conclude that this complication were fewer in younger patient and female gender, and also after ligation of internal iliac aneurysm in comparison to embolization, and with proximal interruption in comparison to distal interruption, but they found there is no significant difference in complication when bilateral interruption compared to unilateral interruption. The last systematic review that I will show, which show buttock claudication in 20% of the patient and the type 2 endoleak in 30.5% of the patient. On the other side, this systemic review, which include 816 patients with preservation of internal iliac artery flow during endovascular aneurysm repair, the results show us that occlusion within the first month in the form of in the percent of 6.6, and occlusion during follow-up 8.8, ischemic symptom during follow-up in 4%, and the endoleak in 4.6, and re-intervention occurred in 7.8. So they conclude in their study that preservation of one or both hypogastric arteries represent a significant improvement in the treatment of aortoiliac aneurysms and have been associated with high technical success and minimal morbidity. The investigators of pelvis registry, which include 6 European centers and include 575 patients, they deploy 650 iliac branch device. They reported complication of endoleak type 1 in only 2% of the patient, and external iliac artery occlusion in 1.5% of the patient. And in their follow-up, the iliac occlusion or endoleak are increased to 4.8 and 4.3. So this is necessary to do a radio operation in 9 patients early, and in the follow-up period in 42 patients. So they conclude that midterm experience with placement of IPDs is associated with low incidence of secondary procedure due to type 1 endoleak and occlusion. This makes us to go to the European Society of Vascular Surgery guideline for elective repair of isolated iliac artery aneurysm. They recommend treatment strategy if the diameter more than 35 millimeter. and less than 35 millimeters, we go for conservative management. There is no available solid data about medical therapy, but we adopt the same medical treatment for AAA, which includes stop smoking and the cardiovascular risk control in the form of antiplatelet therapy, statin, and antihypertensive, with ultrasound follow-up for measurement of the aneurysm. This pushes us to choose the treatment if the size of the iliac artery aneurysm more than 35 millimeter. European Society guideline recommend and adopt the endovascular repair is the best option, as open surgical repair is complicated and may cause iatrogenic injury during surgical repair. EVAR is more suitable due to less mortality and morbidity and reduction of complication, and can be done under local anesthesia. However, given the great variability of the pathology and the anatomy of the disease, we must have both options, EVAR and open surgical repair. If we go for endovascular repair or open repair, we must follow the European Society guideline for preserving blood flow for at least one of internal iliac artery aneurysm, internal iliac artery during repair, and also internal iliac artery embolization. We must do embolization or occlusion at the proximal main stem for better collateral circulation formation. When we choose treatment, we have two equal pathways. The first pathway is to preserve the rescue technique for internal iliac artery in the form of IBDs or flaring limb in the form of bell bottom and barrel grafts. For occlusion, we can use embolization with coil or plug or reversed bell bottom technique. The rescue technique with iliac branch device, the most anatomical limiting factor is formation of aneurysmal dilatation of the hypogastric artery itself, also unsuitable access or unsuitable anatomy in the form proximal neck of this or distal neck of external or hypogastric artery. We have in the market three devices with iliac branch device. The most common used in Egypt is Cook. Also outside there is Gur graft and Jotek graft. We start with iliac branch device from Cook, which is a straight and helic and bifurcated graft, which have an instruction for use of common iliac artery length more than 5 cm, external iliac artery length more than 2 cm, and internal iliac artery length more than 1 cm, and the iliac bifurcation diameter more than 16 mm. This is the Cook Zenith iliac branch device, which have 3 gold markers. Now we're heading to the Gur excluder endoprosthesis, which is a bimodular, which is formed of iliac branch and extension of hypogastric. High conformability and the high flexibility of this graft. It has instruction for use of diameter at the iliac bifurcation of more than 15 mm and the length of external and internal iliac artery more than 1 cm. The last iliac branch device is from Jotek, which is formed by a bifurcated stent which support to the hypogastric artery. This device is has the benefit of being pressure drive release, so gradual or continuous deployment can be done for precise deployment. This figure shows us the deployment of iliac branch device in the ipsilateral limb and introduction of 12 French sheaths and snaring of the wire from the contralateral side. I will show you one cases of our cases after introduction of the main graft, main iliac branch device, then snaring from the contralateral side, then insertion of 12 French sheaths, then insertion of vertebral or bernicastor for cannulation of hypogastric artery and exchange the wire for rosin wire, then deployment of the stent graft in the hypogastric artery and the complete deployment of the iliac branch in the external iliac. And this is the final angiogram which show us the final angiogram showing the patency of internal iliac artery. This is the post-operative CTA. Carolina et al. In their paper of internal iliac artery preservation strategies in the endovascular treatment of aortoiliac aneurysm report technical success of nearly 100% of all patients and the graft patency which nearly 95% at 3 years follow-up. But unfortunately, we sometimes have complication during or after deployment of iliac branch device as kinks or poor runoff or dissections. The other rescue technique for management and the preservation of internal iliac artery is the bell bottom technique, which is a flared iliac extension in the external in the common iliac artery, but the maximum diameter must not exceed 24 millimeter. It has the advantage of being cheap and technically easy and available, but its limitation is anatomical limitation and long-term durability. The same paper reported the data from the bell bottom freedom from re-intervention in 91% of the patient, and endoleak type 1B most commonly if the diameter of common iliac more than 20 millimeter. The last option is using a barrel graft or sandwich technique, which has the benefits of being technically easy also and available and safe and effective, but the most drawback met us is the gutters and anatomical limitation. The same paper reported the data from barrel graft in the form of freedom from re-intervention in 100% of the patient, and the endoleak up to 20% of the patient. So we have to choose at some times to occlude at least one of hypogastric artery to avoid gluteal claudication, which occur up to 28 patients. To occlude one of hypogastric, we have several strategies. We can use coil embolisation or plug and overstenting or reversed bell bottom. If we go for occlusion, we must go through two guidelines. The first is more proximal portion of hypogastric artery is to be occluded to form good circulation, good collateral circulation from the other side. If bilateral occlusion is mandatory, better use a staged operation to form collateral circulation also. This photo shows us the occlusion using coil embolisation. This one shows us the deployment of the plug in the internal iliac artery. This paper shows us the occlusion technique using overstenting, which myself did not adapt this technique, but this study shows that hypogastric artery coverage with endurant endograft without coil embolisation doesn't increase the incidence of endoleak. The last technique for occlusion it is adopted by Sandra Fili in Italy is the reversed bell bottom technique. The reversed bell bottom technique is a strategy for occlusion of the hypogastric in selected patient. If the hypogastric cannot be spared or safely occluded using coil or plug, an integrated approach with contralateral femoral axis and the crossover of aortic bifurcation is performed, then an iliac bell bottom extension is placed in a reversed fashion. Then an iliac extension is inserted and the completion of the EVAR procedure. They reported in this study that this technique has proved to be successful in well-selected cases in which clinical conditions obstruct us from selective cannulation of the hypogastric artery or the placement of the vascular plug or coils. Then I will report our experience in Bologna University in Italy. We published this paper at Journal of Vascular and Intervention Radiology at 2019. Early and late outcome of common iliac aneurysm treated by flared lamps or iliac branch device during endovascular repair. We include 150 patients, in which 105 flared lamp and 57 IBDs. We reported complication in the form of type 1B endoleak, type 3 endoleak, and limb occlusion. In the first 30 days, we reported no complication in the IBD group, but 4 iliac artery occlusion in the flared limb group. In the follow-up with 40 months, we reported 6 iliac complication in the flared limb and no in the IBD group, which caused significant difference, statistically significant. So we conclude that IBDs and flared limb have similar perioperative results. IBDs have a long procedure time and a great contrast medium, but they are associated with lower iliac complication after 4 years of follow-up. So we go for the take-home message. Elective repair of iliac artery aneurysm of more than 35 millimeter or according to AAA diameter, endovascular repair is the first option and best choice. We must preserve at least one of hypogastric. If unilateral occlusion, we use plug for the proximal occlusion. If we obligate to bilateral occlusion, a staged operation is better. And thank you.